Herman's kind of referred to it during his case, and there are a lot of provisos that I want to make about this. We're very excited about this technique. There are a lot of provisos about the data that I'm about to show. And this is called our technique of core isolation for VT ablation. And it's not so much unlike what Andrea's doing. Andrea completely homogenized the whole scar so that there's no electrical signals within it. We're talking about a little bit more limited, directed way of trying to do the same thing. But to take a step backwards, and this is kind of going back to what Shiv said in his comments about substrate ablation, there's a lot of different ways to do this. There's a lot of different paradigms to use to do substrate-based ablation. And my way of looking at it right now is not that one's better than the other, but maybe choice depends on what the characteristics of the scar are like. And it's hard to know that before you get there. So linear lesions, kind of the spokes on the wheel that Shiv was referring to, were the first way of looking at that. And the problem with that strategy is it's very morphology specific. We direct a series of lesions at a specific morphology of ventricular tachycardia. And what that means is that if we don't know about that particular morphology, if we can't reproduce it at the time of the study, then we don't direct any ablation to it. So that's very limited in that sense. Other strategies are trying to get away from the morphology-specific nature of that. Things such as late potential ablation, scar homogenization. This is another one we'd like to add to that list of strategies. So in certain circumstances, and the certain circumstances are still really being defined, but I'll show you some examples. Core isolation is effective and also a relatively efficient way to do substrate-based ablation. So this was the kind of the first case that got us interested in this. This was a patient that was an incessant, very slow ventricular tachycardia, and got to the lab and then was non-inducible, but still had PVCs that had two different morphologies. One that was VT1 escaped from the top half of the scar. One was VT2 and escaped from the bottom half of the scar. And the way that we could tell that was that all of these white dots pacing at every spot within that scar, the upper part of the scar, made a perfect pace map for that VT. And every spot that's labeled in blue, the lower part of that scar, made a perfect pace map for the second VT. What we interpreted this to mean is that looking at the circumference of the scar, there's only two ways to get out. One that would produce VT number 1, one that would produce VT number 2, and the rest of the scar is already isolated from the outside world, whether that's a transmural scar or however else you want to interpret that. Also interestingly is when you got in the middle between those two, Shiv brought up this multi-activation sort of thing. So sometimes we have VT1, sometimes we have VT2. So a very isolated scar kind of makes sense for a very limited ablation to completely isolate the rest of it. And so that's what happened. We ablated the top half of the scar, and after that there was no exit from the top, it could only go to the bottom. And then we made a second line where it seemed that the confluence of that was coming out, and then there was no way to get out. Everything was isolated. We paced from everywhere within the scar and couldn't get to the outside world, and also there were no electrograms recorded there. So with limited ablation, the scar was isolated. And this was successful in this specific patient. So we tried to make that into a larger set of strategies, and there's a couple of different circumstances where we've seen that this can be helpful. So the paper that was reported by my colleague Wendy Zhou was based on a relatively small collection of patients from two different programs, University of Pennsylvania and University of Colorado. We're talking about 44 patients out of a denominator of 566 patients with scar-related VT over a 3-year follow-up of the two places. So it's very anecdotal, very empiric, but we think that there are other ways that this could be extended. Specifically, the points that I want to make is that this is very useful in patients with non-mappable VT, or even with patients who had non-inducible VT. The population was primarily based on heel infarction and often with large scars, with 73% of the patients represented. And in this series, despite the mixed type of disease processes that were encountered, epicardial mapping and ablation was very limited in application. So this is kind of a general approach to things, and this almost looks like what Shiv was talking about. So we think it's very important to at least have a little bit of VT induction to identify the clinical VT and focus whatever attention on that specific thing. If it's mappable VT, we do entrainment mapping and ablate that specifically very discreetly. We may do additional substrate ablation based on that, but that becomes job one. If VT is non-inducible, or if it's unmappable because of hemodynamic instability, then attempts were made to isolate the core. I'm going to show that in pictures rather than in slides, or rather than in words, because there were a couple of different ways that was performed. This is just to make the point that most of these patients had a lot of trouble, big scars. Most of them had ischemic cardiomyopathy. Many presented with VT storm. So this is a very specific case. Kind of starts to illustrate this, but it's a very unusual case as well. This was a patient with a really huge anterior infarction and had inducible VT that was well tolerated. In that experience, we were able to define with entrainment mapping specific areas of the circuit, entrance sites, isthmus sites, exit site, as well as late potentials. So not a lot of late potentials, but we defined where the core of the circuit was really contained. Ablation at this isthmus spot promptly terminated the ventricular tachycardia. But the additional core isolation part of this was ablating around the area where we knew the circuit had to live, just to provide some extra security that this would actually work. No other ablation in the entirety of the rest of this huge scar. This patient was non-inducible and has had no VT in follow-up. So one way of looking at this is that our old bioassay, which no one trusts anymore, is we induce ventricular tachycardia, we do an ablation, and then find it non-inducible. And that fails often. So this is a new bioassay. We induced ventricular tachycardia, we ablated and destroyed it, but then we made the area that was responsible for the circuit completely non-capturable and non-recordable from. So a bioassay that's potentially a little bit more useful than thermal stimulation. A number of other ways that this can work out. So this was a patient with another anterior infarction, but was non-inducible at the time of study. We did have a copy of the clinical VT on 12-lead electrocardiogram, and so we could use pace mapping to try to orient that. Interestingly, these two spots marked with scars in the middle of the, marked with stars in the middle of the scar, both duplicated the pacemaker morphology of the VT almost precisely. In this case, isolation, like Shiv was talking about, of more or less the entirety of the scar. We skipped this part because it was non-excitable at the beginning, but all of the rest of the red zone of the dense scar was ablated around. That did not isolate the scar, as it turned out. This is an activation map of the late potentials in the scar afterwards. And you can see that there's one remaining wick of activation across the scar in the red color here at the right side of the voltage map, showing very uniform propagation to purple, and ablation at this one gap, if you will, resulted in core isolation. No recordable electrograms from the scar, no ability to pace and capture. This also works, and I never thought that it would, with endocardial ablation in a very limited number of patients, albeit, in non-ischemic cardiomyopathy. So we think about that being exclusively an epicardial disease, or nearly so, but some patients with non-ischemic cardiomyopathy still have endocardial VT. In this sense, this was a patient who had no inducible ventricular tachycardia. The scar at the 0.5 millivolt voltage level was completely encircled. There were lots of late potentials here too. We could have approached things that way, but we approached things this way instead. Exit block was demonstrated from pacing within the scar core. All the late potentials went away, and that patient was non-inducible. No epicardial procedure was performed in that patient. So here's what I think the concept of it was in my head, why this would work in ischemic cardiomyopathy. You can see that very often VT in ischemic cardiomyopathy is related to this rim of surviving tissue on the very subendocardial layer, so that if you ablated often a very limited depth of tissue, it would be isolated because you can't get through from there to the epicardial surviving tissue. I also like this slide because it shows something that Furman's dealing with presently. Very often, these inferior infarction scars are shielded by the overlying posterior papillary muscle. And I think a lot of endocardial ablation is limited because we can't reach the scar because there's something in the way. But why would this work in non-ischemic cardiomyopathy? I have to take this a little bit on faith, and we've demonstrated this in a couple of different models that I don't have time to go into right now. But very much, and it's like the Alesse model of the atrium, that the endocardial portion of the atrium and the epicardial portion of the atrium are doing different things. So even more so in the thicker ventricle, there are often scars, even in non-ischemic cardiomyopathy, that segment the endocardium from the epicardium. There is no way that we can ablate through the entirety of the ventricular mass. But if you can ablate the endocardial surface to where that barrier is, the scar can also be isolated. So the way that this went, again, it started with inducible VT, yes or no. A lot of these patients had no inducible VT, so substrate ablation is absolutely necessary. We often, without pace mapping, don't have the ways to really focus where we should ablate within the scar. And so these patients were very likely to be chosen for core isolation. So the first step in this kind of success or failure, whether VT is inducible or not, is whether core isolation is achieved. If it's not achieved, we do more ablation. If it's achieved, we stop. When we had either inducible VT at the beginning of the procedure or not, when we achieved core isolation, we had very excellent VT-free survival at 18 months follow-up. When core isolation was not achieved, VT-free survival was much less good. This is how this looks like based on all the patients. We had 86% freedom from VT recurrence, but this was much higher in patients with the ability to achieve core isolation, and much lower in those that we could not. 38 patients were free of recurrent VT, 6 had recurrence, but even in this group, many benefited. So 3 of the 6 had an only isolated single episode of VT therapy in the follow-up period. So they were technically failures from a Kaplan-Meier perspective, but clinical successes from how well those patients were doing. Importantly also, there was no VT storm in the group that had recurrence. So in conclusion, I think this is another possible strategy that is particularly favored in patients with large healed infarction scars. Sometimes when we can demonstrate that there are only limited sites of egress during pacing within the scar, and in patients who had non-inducible ventricular tachycardia. When we can conclude that, VT core isolation, when it can be achieved, may very well improve the outcomes for VT ablation. The decision to do core isolation, in my opinion, should be selected based on the electrophysiologic characterization of VT circuits, and particularly when we can utilize the existence of fixed anatomical barriers. Dense scar isolation is also an option for non-inducible ventricular tachycardia, and achieving exit block is important, but it's also a very easy bioassay to assess success. We can do that with one catheter. We can pace in one catheter and see if it doesn't capture. We can move that catheter throughout the scar and demonstrate there's no reportable near-field interference. Thank you for your attention.